Hi, everybody. Yeah, I am very excited to be here and part of moderating this powerful women panel, I think I'm going to call it. We're here to talk about advancing equity in obesity care. And with me, to the left, I have Shanice Davis-Colwell, an obesity patient advocate. Welcome. And to her left, Dr. Yasmin Gonzalvo, clinical professor of pharmacy practice at Purdue University. And lastly, we have Dr. Angela Fitch, she obesity medicine physician, board member of the Obesity Action Coalition, and previous president of the Obesity Medicine Association. Welcome. I am Rhonda Pacheco. I guess I should have started with that. But I am Rhonda Pacheco, and I work for Lilly. I've been working for Lilly for about 20 years now, and currently I am leading our U.S. obesity and diabetes business. So let's just jump right in. We're not going to do intros. When you answer your first question, tell us a little bit about yourself so we can get right into this. Dr. Fitch, I'm going to start with you. Hi.
Hello.
The Obesity Medical Association is celebrating its 75th anniversary in April.
75 years.
It's amazing.
Way before GLP-1.
Yeah, yes. And 12 years this June since the American Medical Association classified obesity as a chronic disease. And even today, this discussion keeps evolving, and we're hearing a lot about it. Can you just ground us in some background information about obesity and the science of obesity as a disease?
Yeah, thanks, Rhonda. And thank you all for coming, and thank you for listening. As Rhonda mentioned, I'm Dr. Angela Fitch. I am board certified in internal medicine and pediatrics, so I'm double board certified and did primary care for 10 years in Minneapolis, Minnesota. And then I got board certified in obesity medicine in 2012. So in 2012, there was a board certification to become a specialist in obesity medicine. And as Rhonda mentioned, in 2013, the American Medical Association said obesity is a disease. And I currently am operating chief medical officer of a clinic called KnownWell, where we combine primary care and metabolic health care into one clinic, and we see patients. We have hybrid clinics, so we have a clinic, and then we also have telemedicine, and so we're able to take care of patients all across the country. And so we are setting up clinics. Hopefully, we have one in Dallas, Texas. That's the closest one to here. And we look forward to helping the country solve this obesity disease state and crisis we have right now. So as Rhonda mentioned, obesity is a disease because a disease is something that's a complicated process that has an adverse effect on our health. So if you look up the definition of obesity, it says a chronic disease that is due to the excess accumulation of adiposity, which is the fancy medical term for body fat. So excess adiposity that accumulates in a dysfunctional manner. So this is a dysfunctional accumulation, meaning it's not the patient's fault that they have the disease. Yet, and then that dysfunctional accumulation has to have an adverse effect on your health. And so this is more than just body mass index, like your height and your weight, right? There's a lot of information out there on that, on our body mass index and defining obesity, but that's not how we define obesity. It's a disease state that can have an adverse effect on your health, and that's what we want to focus on. We want to focus on the health of it, not the weight of it, right? And it's really about those health outcomes as it relates to treating that excess adiposity. And again, it's dysfunctional like other diseases, meaning it's not the fault of the patient, but for centuries, we have said in the disease state that this is just about eating less and exercising more. And hopefully throughout the discussion today, you'll come to understand that it's not just about that, because we see a lot of those comments out there, and it's not just about eating less and exercising more. It's a progressive chronic disease, chronic meaning you have to treat it across your whole lifetime, not just in an episodic, one time, or twice, or do it again and again and again for 10 years in a row, right, over and over. But this is something you treat, ongoing forever.
Thank you. Thank you for grounding us. And it is a chronic disease and comes with a lot of stigma. So maybe we'll talk about that today too. But thank you very much for grounding us. I'm going to go, Shanice. How you doing?
I'm good.
Good. So you were someone living with obesity, and now you are a big advocate for others. Can you just share a little bit about your experience with the disease and your own journey with us?
Wow. Yeah. Still, like the doctor said, it's not something that you get treated and it's done. It's an ongoing disease that you struggle with, or may not struggle with, for the rest of your life if you don't find a way to deal with it. I am a bariatric patient. I had bariatric surgery in 2012. Currently maintaining over 120 pounds off over that period of time. I became, thank you very
Yes.
much.
Yes.
But it took a lot of work just to get myself in a position and know what I was going to be dealing with throughout the journey of keeping the weight off. And again, it's still something that I'm going to continue to struggle with for the rest of my life because it is a disease. It is a chronic disease. So putting myself in position where I had the resources, searching for the resources, looking for the resources, connecting with people who could connect me to resources that would allow me to be able to sustain the weight loss.
Great. And you're an advocate?
And I am an advocate, very much an advocate of obesity stigmas and weight loss stigmas, and just being an advocate of helping people to find those resources that I had problems or issues finding when I was trying to start my journey to maintaining my struggle with obesity.
Great. Well, thank you for sharing. Thank you for the courage to come up here and
Thank you
talk.
guys for inviting me. Very passionate about it.
Really appreciate. Everyone needs advocates, so thank you. I'm gonna switch it over to Dr. Yasmin. So curious, pharmacist, from a pharmacist's perspective, how have you seen both provider and consumer understanding of obesity change over the last decade?
I thank you, Rhonda, for the question. And I think, quick intro. So I'm Jasmine Gonzalvo, and I am a clinical professor at Purdue University in Indiana. I'm also the director of our Center for Health Excellence, Quality, and Innovation there. When I have my clinical hat on, I am optimizing medication and providing education for cardiometabolic diseases for our Safety Net Hospital in Indianapolis. And that I've worked across a number of different settings in federally qualified health centers, so providing care for people with a lot of barriers related to optimizing health. My current practice setting is in a clinic that provides care for about 85% Spanish-speaking clientele. Before that, I practiced in a clinic that was primarily served people with serious mental illness. So a lot of the barriers that we're talking about today, I've had a lot of experience with working with those populations. So going back to the question, really thinking about, wait a minute. What was the question? Can you remind me what the question was?
From a pharmacist perspective. Yeah, it was a
Pharmacist.
great intro. I love the intro. We'll get back to the question.
I nailed the intro and then forgot
Yeah,
the
it's
question.
okay. That's why I'm here.
Yeah, perfect.
Oh, you got it?
Nope.
Oh, okay.
Say it again.
From a
Let's do it again.
pharmacist perspective, how have you seen both provider and consumer understanding of obesity kind of evolve over the last decade?
Got it, Rhonda.
You got it. Okay, good.
Okay, so I have definitely seen provider understanding of obesity really grow over the last 10 years. And I think that on the provider side and on the healthcare team side, we know it's a chronic disease and we're familiar with the treatment options. And what I haven't seen catch up quite yet is in people generally, in the population. I don't think that the population in general is ready to talk about obesity as much as the growth that I've seen on the healthcare side of things. And so a great example is, so I work with a lot of students. And when we are working with people who struggle with a lot of cardiometabolic chronic disease, my students can talk about diabetes, for example. My students can talk about cholesterol, for example. But then when I ask them, what are the words that come out of your mouth when you want to talk about obesity? They kind of clam up. Mm-hmm. I don't know how to talk about somebody's weight. And I think it's a mutually kind of bidirectional sort of place that still needs to be explored of how do we have these conversations in the midst of the stigma that exists around obesity and carrying excess weight. I think people in general also aren't necessarily empowered or ready to have those conversations with their healthcare team either. So I think there's a lot of work to be done on both sides of breaking down the barriers about even starting conversations.
Yeah, when we talk to patients, we hear a lot about the shame, and maybe you can talk about that a little bit, but they don't want to bring it up because they feel so ashamed. So I don't want to bring it up, and I'm afraid. And then I'd love to go to you from a physician perspective. You're great at it, but what is that challenge from just a provider perspective, physician perspective, that having to treat patients living with obesity?
Yeah, it is. And we've been doing a lot of work at the Obesity Medicine Association. So we, as Rhonda mentioned, we're celebrating our 75th year this year. So the Obesity Medicine Association is an association of clinicians who care for patients with obesity. So it's our professional society. So we had a professional society for obesity even 75 years ago. So there were enough clinicians together, thinking about it, treating about it, researching it, that we had this, a society to help support them, right? And so again, this isn't necessarily a new topic, but yet it's taken almost those 75 years for a lot of the discussion to get more into places like this even, right? Coming to South by Southwest and having a discussion about obesity where we might not have done that, in years past. It also tends to be, something that, for whatever reason, we don't quite understand this yet, but 70% of our patient population at Knownwell are women also. So it's also an overlying women's health issue a little bit as well. And I think that overlap also is important in that, in medical school, in residency, we don't get a lot of training around some of those types of things like obesity and menopause and other types of things that in particular also affect women. Obviously, obesity affects men as well, but it tends to disproportionately affect women and also women of color too. So again, there are lots of equity things around obesity and also about just the disease state itself and understanding it as a disease instead of this shame and blame, like it's my fault that I did this to myself. And we don't say that about other diseases. So we have to get past that. We have to learn how to talk to patients, which is what we train clinicians in how to do. I'm concerned about how your weight may be affecting your health. Is that something we can talk about today? And understanding, is that something that the person is there and wants to be open to talking about that right now? And if not, coming to terms with that and then maybe bringing it up again.
Dr. Yasmin, you talked a little bit about barriers. I might toss this to both of you because both providers. What have you encountered, maybe continue to encounter around barriers of treating patients living with obesity?
I think medications in general, usually when we're talking about chronic disease states and access to medications, that's a huge barrier that we continue to see for people who want access to medications. It's a complicated landscape, navigating medication access. So that's definitely a piece that I've seen throughout my career, as well as what I mentioned before is if we can't even start the conversation, then are we even getting to those discussions of what medications might even be helpful in that space?
So conversation, access to medicines. Yeah.
Well, and one of the key pieces that you have to understand and level set for the moment is that obesity as a disease is not a standard benefit on our insurance in the United States. So it's not a standard benefit. It's carved out of the insurance policy because many years ago, when this was set up this way with our commercial insurance plans provided by your employer, predominantly, when you have insurance provided by your employer, you don't have to ask your employer, do you cover high blood pressure? Do you cover diabetes? Do you cover cancer if I get cancer? No, because there's standard benefits on your commercial plan. But obesity was carved out many years ago because it was thought to be cosmetic. And most insurances don't cover cosmetic procedures. And so many, many years ago, it was thought that this is a cosmetic problem only, an aesthetic problem, that it wasn't a disease, right? Because it wasn't until 2013 that we actually said it is a real disease because we understand it now from a science perspective, why it is a disease. And so again, because of that, we haven't, the world hasn't caught up yet. So we're fortunate, thank you so much if you're an employer in the room that adds that obesity care, because we're fortunate that about, some data shows probably about 48% of employers, maybe it's a little higher even now, they actually choose access. So I think a lot of times as a clinician, you don't also want to talk about it because you don't know if you're going to be able to treat it, because it's actually carved out. So if it's carved out of your plan and I bill for it because you're coming into the office to see me, you come into the office to see me for a cough or cold or pneumonia or name the disease you come in with, I can bill that. I can say this person has pneumonia, and then I, send that bill to your insurance, to get paid for that 20-minute visit that we spend together, dealing with your issues. And so again, that doesn't happen if you have a carve out of your insurance plan, if you don't have coverage for that. And so again, this is the challenge we have, I think, at a fundamental level that I like to talk about when I have opportunities to, is it needs to be a standard benefit, which is at the Obesity Action Coalition, which is the patient advocacy arm for obesity. We've been lobbying for the Treat and Reduce Obesity Act, which would allow Medicare to cover it. Because the argument of commercial insurance is, if Medicare doesn't cover it, then we don't have to cover it. And so again, I think as we get Medicare, I've been, walking on Capitol Hill for 12 years, trying to get this bill passed. And if we can get that bill passed, then of course, hopefully then it would become a standard benefit and we wouldn't have to deal with some of the things that we're dealing with from an access and equity issue.
Yeah, thank you. The healthcare system is not a simple one as you go through all that. I'm going to switch gears a little bit into the patient. And so we talked about barriers. Access is a big one. We need policy change. It's going to take all of us to really tackle those barriers. And thank you for, I know you guys both are doing a lot there. From a patient perspective, what are the barriers you've encountered? And also now that you're an advocate too, what are you hearing that those barriers are?
I first want to say it's interesting that now providers and healthcare organizations are discussing this amongst themselves on how to help people deal with the disease of obesity. Because from my research, again, I had surgery in 2012 before obesity was considered a disease, chronic disease. And my experience is that the people that I talk to, that little communities that we kind of hobnob in talking about obesity and the struggles that we were having, was that our physicians weren't listening. They weren't taking into account that we were wanting to do something about our weight and our health other than just stop eating or eat less and move more. Yeah. Experience with my own physician. I love her, but she just went all the way around my issue. She talked around my issue. She didn't want to address them head on until I made the decision to tell her, look, I really want to do something about this. Can you help me? She sent me to a dietitian. That helped, but it didn't really solve the issue. It was a very complicated issue dealing with her with trying to get some help for myself. So I had to advocate for myself. I had to do my own research. I had to connect with people who had already had bariatric surgery, or just find ways to get the knowledge and the information that I needed for myself to figure out what my next move was for what I wanted to do. And I presented all of that to her, and she still wasn't trying to hear it. She thought it was a horrible idea. I don't think you should do this. And after doing more research, I came to her and said, I think this is what I want to do, and I really need your support. But there are a lot of physicians out there, a lot of situations where people I've spoken to had the exact same thing. Their physician didn't want to, I don't want to say didn't want to help. They were not very helpful on the journey to getting the surgery or getting the help that they needed outside of the normal channels of, let's send you to a dietitian, or, let's just put you on this diet or put you on that diet. So for me, it was the opposite. The physician didn't want to hear it. It wasn't conversations that I'm guessing were being had in the healthcare community amongst providers to help their patients, or to even acknowledge or hear their patients were struggling with this. So that's just interesting that, and very encouraging that these conversations are now being had amongst the.
And I just want to echo, well, first of all, Shanice, amazing that you kept on pushing
Dog
for
with
that.
a bone, dog with a bone.
And look at you now, right? That's incredible. But not everybody's going to do that,
Exactly.
right? And when they're shut down, when they go to clinic or wherever, that might be it. That might have been the opportunity for
Absolutely.
something to happen. And I think, especially when it comes to primary care, and working in a federally qualified health center where there are a lot of people who have obesity in the setting that I practice in. A lot of times, what I know is happening, and I like how you gave credit to the physician. You're like, well, it's not they don't want to, but I also with a lot of the providers who I work with, they don't know what to do. I'm going to send you to a dietitian because I know that one's easy, right? Or I know this, and I can hit a button and that's going to happen. It's so complex, though, of the number of things that a provider might have to do to actually address the holistic needs of somebody who really is interested in losing weight, and not to mention that the process is hard itself, right? So it's complex, and I think that there's a lot of work to do, and we have a lot of opportunities. But as we sit up here and we have these conversations, we're doing something. I would like to believe that we're doing something.
Absolutely.
In creating strategies that do make it easier for people who are in a similar situation as you were.
Yeah, hearing each other, listening to each other, trying to figure out what those needs are and where the missing pieces are. My physician that bariatrics was not her thing. She's not a bariatric surgeon. She only knew what she heard from, other patients who may have had it, and, that wasn't a good experience for them. And for the most part, a lot of people don't have a great experience with it. But when I made up my mind that is what I was going to do, I tried my very best to tap all of the resources that would give me a very full picture, or as clear a picture as I could get, of what to expect and what I needed to do, the accountability that I needed to take to be successful and not be just a number or a person who did it and didn't succeed. So I wanted to set myself up for success, which is how I became an advocate. I want other people to know that there are resources because, like you said, some people will ask their provider and, get shot down or get sent, through all these different channels that don't help them. And then they get discouraged and say, okay, well, this is just it. This is what it's going to be. And they give up. And I want to be able to show people that, if this avenue doesn't work, then try this avenue. Just giving people resources and making sure that everybody's on the same page with helping people find those resources.
Yeah. Thank you. Great discussion. Dr. Jasmine, I'm going to come back to you. You are so passionate about this, and just talking to you for the last couple hours, it comes out. Maybe share what you've done from a community work and how you're helping tackle this. And it's going to take you and all of us and so many others, but maybe share a little bit about what you're doing.
I'm not going to stand up and get on a pedestal right now, but I am very passionate about this. And I think there's so much opportunity, right? And so some of the work that I've done, when we say we do community work, I have found that some people walk the walk and talk the talk, but you really differentiate who is actually working with communities and listening to community voices versus just kind of like doing the drill, right? Going through motions. Yeah. So one of the things that we've done, really listening to the voices of communities in a medically underserved area, there's a really large food pantry in our neighborhood. And this food pantry serves about close to 30,000 people at any given moment. And what this food pantry has committed to is actually building a resource room where they can connect people who are using the pantry to social service resources. So that might be a diaper bank, that might be an area agency on aging in terms of helping their neighbors connect to caregiver resources, for example. That may be connecting to WIC, right? But what we are also doing, and having my pharmacist hat on, we're also implementing a charitable pharmacy on site in the resource room at the food pantry. So when we talk about improving access, we know that when we're sitting at a clinic, that we are missing people. People are not coming to us. And particularly, I was just talking about this at lunch, saying, you know, being in a clinic that serves people 85% Spanish speaking, in the last 1 to 2 months, people aren't showing up. They're not answering their phones. They're not coming to clinic. And I'll let you all decide why that may or may not be. So when we are talking about improving healthcare disparities, we really need to be talking about meeting the community in places where the community already is, and not expecting people to take time off from work and take the bus and have basically their whole day to maybe even be late for their appointment and then have it be canceled. That's not working. It's not working, and it's maintaining the status quo of the existing health disparities that we have. And it's just going to continue to get worse until we find these innovative models where we truly do listen to the community and show up in the spaces where the community already has needs and already will be. So if we know that at this food bank that there's going to be thousands of people every week, week after week, why aren't we there? What took us so long to get there, right? And that also, that conversation's for another day, right? I just think that the work that we're doing is really listening to the voices of, the survey that we learned this from was called the Voices of Our Neighbors survey. And listening to people saying that they had problems accessing medications, affording medications, taking off of work to get to medical appointments. That was really so much of the data that really fed our community initiative to really just work with the food pantry in a medically underserved area to bring those resources to them. And I'm really excited. I'm chomping at the bit to really implement all of the things that need to be in place and see how we really do start to move the needle with a lot of these healthcare disparities that we've just been sort of that's not fair, not twiddling our thumbs, but we haven't found the solutions. We haven't found the most effective solutions yet.
Yeah.
Well, and one thing we didn't mention is, why, maybe you're a clinician, other than the education around the disease state, and the standard of care, like the lack of coverage, is that there's also a lot of administrative burden to this disease, right? That doesn't have to necessarily be there. And so that's what we also have to work on, getting rid of, right? Some of that, meaning I have to fill out 40 forms and write a letter in order to get you access to your medication, right? If everybody has to fill out 40 is a little bit too much. But my staff fills out a form, they get a rejection on the form because something was put wrong, and then they have to fill out the form again. And all these staff are people that are hired that aren't, we can't get any reimbursement for their services. So in other words, it's all an added expense to the healthcare system, right? And I like to put a plug in for access with telemedicine too, right? Because telemedicine, I think, has really changed our ability to do virtual visits. We do it, video. I'm talking telemedicine, not filling out a form on the internet and getting something mailed to your house. But I'm talking about actually having a relationship with clinicians, whether it's a dietitian or physician or pharmacist, on these platforms, to be able to deliver that care. And we're at risk of that not being an option because they just extended, hopefully Congress will vote to extend the Medicare flexibilities that were given during COVID, and they're planning to extend it to at least the end of September. But if we don't change the policies around telemedicine and coverage of telemedicine, it's going to hurt us versus, set us back quite a ways versus allowing us to move forward, especially around accessing, people not having to leave work, people able to get on their cell phone as long as they have a cell phone. And there's a lot of programs now to get people cell phones as well. So being able to do that, I think, is key.
The one thing you said around solutions. So at Lilly, we talk to a lot of people. We are trying to listen to everyone we talk to, but really identifying solutions to these challenges that we're all talking about. And one of the things that we implemented, so we've been in diabetes for a very long time. When we have the Diabetes Impact Project that's in our hometown in Indianapolis, where our headquarters are. But it really, I think the key is going to them in the trust that's already in that community. And we're talking about equity. Like, people are not going to raise their hand and you did it, but a lot don't go and find it. So going to them, finding the community, local businesses, advocacy groups that they trust, and then providing education and culturally relevant information is another whole nother topic we could probably talk about for an hour. Making sure that we help with the access to the education through these communities, access and continuing to work for access to these treatments. But that was just, we're learning a lot from that program, and we're gonna try to continue that and move into the obesity space. But the key is that community work is so critical. You guys are shaking your head, like you know, like activating that is really important for these patients. I'm gonna stay on this solutions part, and so Shanice, as a patient advocate, tell us maybe what solutions, when you had to navigate this very hard problem, what did you find that was most impactful, and what providing you advice? And you talked a lot about resources, but maybe share what those resources were that helped you, and maybe now you're using to help others.
My first resource was trying to find community groups that talked about obesity and the struggles with dealing with dealing with obesity. And my first group that I found was an online community called Obesity Help. I haven't visited that site in so long. I'm not sure if it's still up and running, but that was the very first one. I had conversations and interacted with that community, people chatting about their struggles and things that they've done, and having bariatric surgery and having the sleeve and things like that, and comparing. So all of those conversations kind of led me down the rabbit hole. And I started looking into other things. So I found Your Weight Matters now. Obesity Action Coalition was the very next one, and that was the biggest help for me in finding my way to being able to have that crucial conversation with my physician. And once I did that, it's like the floodgates open, and I'm like, okay, everywhere, just trying to find those resources to get me going. So it's about getting my foot in the door to getting what I needed. And then once I got what I needed, finding a way to maintain that and the resources that come pre and post surgery. So, you know, the struggle is before, the struggle is during, and the struggle is after. So, you know, setting myself up so that I would be able to navigate the journey with everything that I needed to be successful.
Is that where you direct your... Yeah,
absolutely.
tell us a little bit about
absolutely. It also led me to be a resource. I wanted to be a resource. I wanted to be as instrumental to other people as the resources that I came across were for me. That led me to being a health coach, to getting a health coach certification, to getting